And we've also got Ranjan Patel, who is also a facilitator at CEG. Just a little bit of housekeeping just before we start. So if you've got a question, if you could type it into the Q&A box. I think everybody's familiar with Microsoft Teams now, and we'll monitor it, and at the end we'll go through all the questions. Secondly, somebody has asked already that about recording, and yes, we are recording this because we want to put it up on our website afterwards, and there'll be some parts in this that you may want to just refresh afterwards. I'm going to ask that everybody is muted, and also if everybody can switch their video off as well, just for the purposes of the presentation, and then afterwards we can unmute if you want to make any comments. Okay, next slide, please. So what are we going to cover? We're going to give you a brief overview of the Investment and Impact Fund indicators up to March 2022, and we're going to focus more on the new October indicators. We're also going to demonstrate the CEG products that we've developed to support certain aspects of this DES IIF. And I'm going to just hand over now to Ranjan, who's going to go through and describe the indicators for you.
Thank you, Jo. So the focus from April 2021, IIF indicators are introduced in phases. And this year is about preparation, which will lead to more comprehensive IIFs from April. Today, we will briefly cover on the criteria, which is part of the Network DES contract. The main focus is on improving on prevention and tackling health inequalities. This focuses on detecting diseases early, preventing deterioration of health, and reducing symptoms to improve quality of life, especially those in vulnerable groups. As you know, COVID-19 pandemic highlighted health outcomes from different groups, and the expectation is to identify and engage in designing together on how the needs of these groups are met. Supporting better patient outcomes in the community. This is looking at care homes and providing more personalized care and to avoid hospital admissions where possible. Supporting improved patient access. So access has been a core aim for NHS long-term plan. And due to pandemic, access to general practice has changed significantly. So this is to support patients get the right care at the right time and place. Delivering better outcomes for patients on medication. This is looking at medication safety through structured medication reviews. Helping to create a more sustainable NHS. The aim here is to lower carbon emissions through changes in inhalers. The maximum point per PCN achievable are 666 at £200 per point, adjusted to list size prevalence. Influenza indicators commenced in April. Although the flu season starts later in the year, it is what you're doing already. So the three indicator criteria for influenza vaccination are age 65 and over, 18 to 64 and in clinical risk groups, children aged 2 to 3. The total points achievable here are 142. Learning difficulties, disabilities, health checks and action plan for age 14 and over. This is something practices are doing already, so just continue with that. Referral to social prescribing. And access was to confirm that all practices had mapped active appointment slots types to the new appointment criteria, and this ended on 31st of July 2021. So the changes from 1st of October 21. Number of online consultation submissions received by PCNs per 1,000 registered patients. This is running from January 22 to March 22. So PCN practice members are to sign up to any data provision notice to be able to earn the points. So online access is a contractual requirement from 1st of October. Purpose of this indicator is for practices to provide and promote online access to patients who choose to use it. Analyze and discuss implications and implement a plan to reduce any attendances for minor conditions with integrated care systems. To make a plan to reduce unnecessary attendances and admissions by appropriately directing patients to local services, such as local community urgent response or mental health crisis and community services. Collaborate with local community pharmacies, increase referrals to community pharmacy services. So PCNs are to develop and commence delivery of a plan by end of March on how referrals can be increased to community pharmacies consultation services. Through patient survey results, identify those experiencing inequalities of access to general practice to develop and implement a plan to improve access. CVD prevention and diagnosis, improving hypertension case finding and diagnosing. So there are more than 30% of hypertension cases remain undiagnosed according to Public Health England, and the prevalence gap is increasing in younger age groups. This is expected to worsen due to the impact of COVID-19 on routine blood pressure monitoring. So CVD1 is age 18 and over, not on hypertension QOF register as of 30th of September 2021, who have last blood pressure recording of 140/90 and over in the last 2 years leading to 1st of October. So this is from 30th of September 2019 and to continue from 1st of October onwards. We have added also blood pressure reading of 135/85, and this is for in the community-based setting. To identify those who are not appropriately diagnosed to have a follow-up to confirm or exclude diagnosis by 31st of March 2021. CVD2 is a percentage of patients on QOF hypertension register. Increase of patients on QOF hypertension register. So the expectation here is that the number of hypertension diagnoses will rise through CVD1 criteria, increasing in prevalence in hypertension QOF register from 1st of April will count towards the achievements. Ethnicity. Record ethnicity for all patients or patients who have chosen not to provide ethnicity. So ethnicity recorded as not stated or refusal using correct codes will count. Patients should be given an opportunity to make the decision. Enhance health in care homes. Age 18 and over, identify and record as living in care home, temporary or permanent residence. These are patients living in nursing home, residential homes, care homes, and temporary in care homes. Personalised care and support plan agreed or reviewed, and receiving structured medication review for permanent residents. This is from April 21, will count towards the achievement. Receiving weekly care home round. The appointment doesn't need to be face-to-face. Appointments with status of attended, booked, or DNA will count towards this indicator. MDI prescription reductions. Reductions of metered dose inhalers for ages 12 and over. So the aim here is to reduce MDIs to reduce carbon emission. Alternative to MDI, for example, are dry powdered inhalers or soft mist inhalers. They offer lower carbon emission. Carbon emission per salbutamol inhalers. So salbutamol metered dose inhalers are the single biggest source of carbon emissions in the NHS medication prescribing. This indicator is looking at reviewing and making changes. The calculation of this weighted average will be reviewed annually. So for more information on all the indicators mentioned, we have added links that will be sent out to you with the slides. I'll now pass you over to Joe.
Thank you, Ranjan. Can I have the next slide? Thank you. I just want to mention a word about exclusions and exceptions. And this you'll be aware of in line with QOF exclusions and exceptions. So exclusion, you may get an exclusion applied to some of the indicators, and that'll remove patients and any services or interventions they receive from the denominator for that indicator. An example of this might be that in the CVD indicator, patients who are on the palliative care register will be excluded. Then you've got what used to be called exceptions, but are now called personalised care adjustments, or PCAs, and they may be applied to some indicators removing patients from the denominator unless the action does occur later. So an example of this, if somebody may at the beginning of the year say, I don't want a learning disabilities health assessment, so that's the code that's in there declined, it takes them out of the denominator. But then later in the year, you actually do the learning disabilities health assessment, and so they will be included in the numerator, very similar to the way QOF works. Next slide, please. So as I said at the beginning, we want to demonstrate the support products that we've produced to help you achieve some of the indicators in this PCN DES. We've developed a suite of IIF searches, and we've developed these in collaboration with another group called Primary Care IT. We also have CEG templates available to help you code so that you're accurately coding for these indicators. And then I'm going to show you a couple of dashboards. Next slide, please. We produce resources for both System 1 practices and for EMIS practices. So we mirror what we do in EMIS for System 1. In System 1, you'll see a folder, PCN IIF, and in that folder, you'll start to see these suite of searches. I'm going to demonstrate using EMIS, as I'm actually personally more comfortable with using EMIS. So I'm going to swap now, and I'm going to share my screen so we can go through some of the indicators and the searches that we've got on EMIS. Give me a minute while I do this. I'll probably have to log back into EMIS actually, so. Let's see if it comes up okay. Yep. Okay. So I'm going to share. Can you see my EMIS screen? Is that clear?
Yes, Joe, we can see it, yes.
Okay. Okay. Well, I'm currently in City and Hackney EMIS, our domain for City and Hackney. There's a folder called Practice Support, and that'll be the same throughout all the localities. And you'll go down to this folder here called QOF and DES Support. You'll then see another folder called PCN IIF 2021 to 22. We're on version 2 at the moment, but we will be updating this version to version 3 because we've had some feedback from practices, and we're also working on a couple of other indicators. You'll need to copy that folder across to your own domain because then you can run the searches as and when you want to. I'm going to walk through the searches and the folders that we've got here. So care home coding. In this folder, we have a support search for you. One of the aims of the IIF is to improve coding of care home status. So this support search, if I just show you, I'm going to edit it for you. What you can do in this search is you can enter the name of the residential or nursing home that you are looking after. Then when you run that search, it'll give you a list of all those patients who have got that home as their address. You can then check that list to make sure that they're accurately coded with either living in a care home, living in a residential home, living in a nursing home, or if you've got somebody who's just moved into the care home for a couple of weeks or a couple of months, you can code that person as lives temporarily in care home. And that's important, and you'll see why when we come to looking at the indicators. If the person, after having lived, for a couple of months in the care home, then moves back home, make sure you then code that they lives in own home, as that code will supersede the previous one. Okay, the next folder is also a support search, and this relates to the CVD01 indicator, which is looking at people with previous BPs greater than 140/90. So in this folder, you've got your eligible cohort. And as you can see in City and Hackney, it's actually come up, and this is the same throughout the localities, with quite a large number of patients. So we decided that we'd split this into smaller cohorts to make it easier for the practices. So the first cohort, case finding group 1, highest risks, and these are patients whose BP up until the 30th of September 2021 was more than 180 systolic or 120 diastolic. And as you can see, when you look at the search, although you've got the label there, if you look at the description, you often get a bit more information about the search. From that search comes a report, and I'm going to show you separately what that report will look like. Then you've got case finding group 2. These are patients whose latest BP was more than 160 or 100 diastolic, and that'll exclude patients from group 1. Then we go down to the group 3. So group 3 is excluding group 1 and group 2, and it's split into group 3A, patients with BP over 140/90. But in this group A, it'll look for patients who have either got a long-term condition, or they might have come from a certain ethnic group, or they're high BMI. And then your last group is everybody else, so excludes group 1, group 2, group 3A, and these are patients, again, with BP over 140/90. It also says 135/85. This is only picking up people who've been coded with home blood pressure monitoring or ambulatory blood pressure monitoring, so more in the community settings. Then we've got these little 2 searches here, BP measured since QSSD. QSSD just means quality service start date. So in this situation, it'll be on the 1st of October. So it'll give you an indication of how you're running since the 1st of October with that eligible cohort. And that last one is hypertension diagnosed since the quality service start date. So again, that'll give you an indication of how many people have been diagnosed since that date. Now, I did say we've got these three little reports here. Or have I got more than that? 1, 2, 3, 4 reports here. So I'm just going to switch screens because I want to show you what that comes up with. So again, bear with me just for a couple of seconds. Oh, let me move that out of the way and then I can make it a bit bigger. Okay, so when you run that little report, what you will see is you'll get a patient level report. You'll be able to see, I've cropped this off here, obviously, for so we're not including patient details. But what you'll see is you'll see patient names down on this side. Then it says gender, and then in this second column, you'll have the most recent BP before the end of September, which actually brought the person into that eligible cohort. So if we look at this first person, a male, blood pressure on the 13th of September was 160/90. We've also included the column to the left-hand side, which would be the BP before that as well, and that just gives you a little bit more granularity. The next column here, history of hypertension, this will pick up codes if somebody's got hypertension resolved. For example, this person in 2007 seemed to have this code here, but it might be with a BP over 150/100 that when you do your follow-up, the person actually does have hypertension. Then if you ran this search again, you would see that the person had the hypertension code. Then we've got columns for the codes that bring the person into having had some sort of follow-up. And they're looking for follow-up of things like ambulatory blood pressure monitoring, home blood pressure monitoring, medication change, urgent referral, or their BP goes down, so it's lower than 140/90. So this column here will give you an indication of some of the follow-up codes. Then we've got BP monitoring declined. At the beginning, I said there were some PCAs, and the PCAs for this group of patient is ambulatory blood pressure monitoring declined, home blood pressure monitoring declined, and hypertensive treatment declined. The one that they haven't included in the business rules is blood pressure refused. So if you put that in, it's not a PCA. But what we did do is we decided to include this in the column so that you could actually see who has declined. And then the last column is BP since October 2021, so you can see what the person's blood pressure is now. So that's an example of the reports. Again, I'm going to stop sharing and I'm going to go back into EMIS. Okay, so that's that little suite of searches there. In the next folder, there's a whole load of data quality reports. You can run these as and when you want, and you can investigate patients who may have a code that is not part of the business rule set. So for example, you can see here in City and Hackney, possible incorrect or missing codes for the personalised care and support plan, which is part of the indicators for care home. So practice may well have done the work, but they haven't actually put the correct code for the business rules. So you'd be able to go through those patients and then correct as necessary. So as I said, you can run this as and when you want to. If I come out to the top here now, I'm going to show you the rest of the indicators. The IIF subsets are the denominator, so I'm not going to go through those. So first one, CVD2, patients on the hypertension register. As Ranjan said, at the end of the year, they'll be looking for a percentage increase in this hypertension register, and that's likely if you've done the work on the case finding for hypertension. Patients living in a care home. These are patients that you've coded with those codes that I mentioned earlier, and you can, as I said, match that with the support search that I showed you. Care home residents who had a personalised care and support plan agreed or reviewed. These are for all patients who are living in a care home, so that includes patients who you've also coded as temporarily living in a care home. That's different to this search here, Enhanced Health and Care Home 03, in that these patients are patients who have had a structured medication review, but if somebody is coded as temporarily living in the care home, they will not be included in the denominator. Then we've got a couple of searches here. So this is the metered dose inhalers, and as you can, if you remember, Ranjan said it's the ratio of metered dose inhalers compared to the non-salbutamol inhaler prescription issues. So these, as you can see, are slightly different looking searches, and they come out as reports. Again, I'm sorry, but I'm going to have to just stop sharing here so I can show you what this looks like in a report. Okay, let me share again. Oops, I can't seem to move that little box. Oops, sorry, let me just undo that. Share again. And can you see that okay? It's the next one down, the example of this report. So in this example, what we've got, as I said, first search, metered dose inhalers, and you will see that when you run the search, you'll see a number of months down here, but also the number of issues. So you've got 72 in total at the moment of metered dose inhalers. How many non-salbutamol inhalers? We've got 111. So 72 over 111 gives you 65% of the non-salbutamol inhalers are metered dose inhalers. And what the indicator is looking for is it's looking for a drop. So it's going down rather than up. Again, I'm going to stop sharing and I'm going to come back to EMIS. LD health check completed. LD health check You will probably be doing your LD health checks also as part of your quality improvement for QOF, and also in some of the localities I know that they're doing LD health checks and action plans as part of their enhanced services. So this is an additional income stream for the LD health checks. One other point to make here is that we do offer practices prevalence improvement searches, and in the prevalence improvement folder you'll find searches for learning disabilities, and it might be worth looking through those, running those, and seeing if you can identify patients who have a code that looks like they should be on the register, but again they haven't got the correct QOF code to put them on the register. Patients with a recording of ethnicity, yeah, that I think is quite clear, but again to highlight that the code not stated will be seen as a success, so it'd be pulled into the numerator. Patients referred to social prescribing. Social prescribing, what they're looking at here are the numbers of patients actually referred. Offer of social prescribing is not included. And also remember that if you've got a social prescriber who's in the practice, or who is a PCN social prescriber, please make sure that you put the code that you've referred to them, and then it'll be included in here. The flu vaccination suite of searches, this again is a supplementary income. You've already got your enhanced services for flu, and you've got your IIF payments of about £10 for injections given, flu given. This is an additional source of funding, and they're looking at here over 65s given the flu vaccination, patients aged 18 to 64 given the flu vaccination, but in this group they're only looking at patients in the clinical risk groups. So these will be patients with diabetes, immunosuppression, CHD, BMI above 40, etc. And then you've got your patients aged 2 to 3 given the flu vaccination. So this is the suite of searches. You may notice that we haven't got an IIF CVD01, which relates to the case finding one and the follow-up. It's quite a complex search, so we're just working on that, but we aim to get that ready either at the end of this week or next week. So you'll see that search in version 2. Okay, I'm going to stop sharing EMIS. I don't think there's anything else I need to say more on EMIS, and I'm just going to then ask Ranjan if she can share the slides again so I can just a few more comments on things. Ranjan, are you okay putting up the slides? Thank you. Can we just zip through all of that actually? Because I didn't have, I've shown you that using EMIS, so we don't need these ones. Okay. Templates. So what we've got available for you to use is we've got a number of templates that will help you with the IIF. We have built a standalone RP, it's called Case Finding Hypertension Template. In here, you'll be able to record blood pressure, pulse rate, pulse rhythm, and Q risk, and urine albumin creatinine ratio, which will help you in your diagnosing of hypertension. There's a little bit down there about the PCN, what the indicator is. And then we've also included ambulatory blood pressure. So if you're doing that, you can record the values there. You can record the home blood pressure monitoring as well. We've also included in that template, we have codes for the exception reporting, which, as I mentioned, or the PCAs rather, I should say PCAs, things like ambulatory blood pressure monitoring declined. This page will also be part of the long-term conditions SMART template. So you can either use it as a standalone one, or it is available in the LTC template. We also have just a note about templates. We also have the care home template. So please do use the care home template, because then you'll be accurately using the codes for the PCS-DES indicators. Next slide, please. Okay, that's, as I said, just a little bit more about the case finding template, but we can move on from that one, Ranjan. Thank you. Okay, there's a number of dashboards to help you with this. There's the NHS Viewpoint dashboard. This is a PCN dashboard that isn't built by us. This is built by NHS, and you need to register on the Insights platform, and that'll give you indications of how your PCN is doing. However, we are also, and we built a PCN IIF dashboard from the beginning of April. That had just the very few indicators that started in April, and we're currently updating that so we can include all the new indicators that have started in October. That dashboard is available on our CEG website. If this image isn't familiar to you, please get in contact with your locality facilitators who will be able to give you logins so that you can see not just the IIF dashboard, but you'll also be able to see all the other dashboards, including things like our COVID vaccination dashboards, flu, and local enhanced ones on the website. So, as I said, if this isn't familiar with you, please contact your locality facilitator. Next slide, please. We have got sight of the new indicators for 2022 to 23, which is great because it means that we can start preparing early as you as PCNs and practices also can do. I'm going to just race through some of the new indicators, and just remember that some of the indicators from this year, of course, also do roll over for next year as well. So next year, what are they going to be looking at? They're looking at statin use in patients with Q risk greater than 20%. They're looking at referrals for assessment for familial hypercholesteremia in patients with high cholesterol levels. Enhanced care home, there's more indicators on around care homes, standardized number of emergency admissions per 100 care home residents. Access, there's stuff on access, standardized number of emergency admissions for specified ambulatory care sensitive conditions, utilization of specialist advice, percentage of patients waiting less than 2 weeks for appointments, numbers of referrals to community pharmacists. Next slide, please, Ranjan. And there's still more. They've brought in, or they will be bringing in, a suite of searches for meds review. So patients eligible to receive structured medication review. This dovetails with your other days around the structured medication reviews. They're looking at gastroprotection prescribing with long-term non-steroidals or antiplatelet use. Annual DOAC monitoring as part of, to support the annual DOAC monitoring, we are including a DOAC page in our long-term condition template. Respiratory, regular ICS prescribing in asthmatics, and high SABA use in asthmatics. So these are the things that are coming in 2022. Next slide, please. Handy tips. I thought I'd just do one slide, which just gives, because we've covered quite a lot, really, and I just wanted to flag up a few things just as aid memoirs, really. As I said about ethnicity, people coded as having chosen not to state their ethnicity counts as a valid recording of ethnicity and therefore is seen as a success for that indicator. The CVD one, again, just to note, patients declining a BP reading alone doesn't trigger a PCA. Social prescribing, as I said, make sure you code referral because it's not counting offers. And if you've got a referral form for social prescribers in your system, attach the code to it for refer to social prescribing. Social prescribing is also part of our templates, so you can code through the templates as well. As Ranjan mentioned, sign up for the GPAD data provision notice so that any patient contacts recorded in appointment books can be extracted. That you need to do, and I'm sure PCNs know more about this than me actually, but that you need to do for the ward round in the care homes indicator. And as I said, please use our prevalence searches because this will support you in case identification, not just for learning disabilities. Actually, we have a whole suite for a lot of the other domains for QOF as well. So please use those. Next slide, please. This slide just gives, it gives the names of your locality facilitators. And as I said, you know, they are there to support you. They're there to help you. So please contact them if you've got any questions, not just about the support stuff that we're doing for the Impact and Investment Fund, but for any other support, around QoF, your DESs, and your enhanced services. That was me done. So I think we can open up and see if there's any questions, or if people want to raise their hands and ask a question, please feel free to do so now. Ranjan, did we get any questions? Have we had any
No.
outstanding ones that haven't been answered?
Keith has been answering them in the chat.
Answering them.
Okay, okay. So does anybody want to raise anything else that maybe you'd like covered, or questions? Got a few more minutes. Could I ask if baseline data will be included in the dashboard? Yes, Lucy would like to include baseline data, so then you know how you're progressing through. And just a word on the dashboards, actually at the beginning of the year we were producing it quarterly, but we aim to do it monthly. Are there any other hands? I can't actually see hands. Can you, Ranjan? I can't see any hands.
There was a hand raised, but they removed it, so I don't know if you've answered their question or.
Okay. Can health and well-being coach referral be included? We could include that. There is a lot in the, I mean, we've just focused here on the investment and impact fund of the network contract enhanced service. So there are a lot of other indicators that are part of the bigger contract. And yes, it would be great if we can include those in our dashboard as well. It's just a little matter of being pragmatic, actually, and about what we can do. But we can have a look at that point there, I think. If there isn't anything else, it's just to say thank you so much for giving us your time and actually attending this webinar. And we do have an evaluation form. Any feedback's very helpful, not just about this webinar, but maybe if there's other stuff that you'd like us to do webinars about, we'd be very pleased to hear your ideas. Charlotte, have you put the link in somewhere?
I have just put it in the chat. I'll also send it over via email as well in case anyone's left early.
Okay. So does that mean if it's in the chat that people will be able to access it when we've come out of this? Is that right,
Yes,
Charlotte?
that's correct.
Okay, brilliant. Thank you so much, everybody.
Thank
And, thanks to Ranjan for her part of the presentation as well. So many thanks.
Thank you.
Bye.